Hello, everyone. Welcome back to Wally's nursing videos. In today's lecture, we're diving into the essential topic of nursing care for patients with musculoskeletal problems. By the end of this class, you will be well versed in understanding age-related changes to the musculoskeletal system, interpreting diagnostic data, managing various musculoskeletal disorders, and providing care to those undergoing orthopedic surgery. Today, we have a lot to cover. By the end of this lecture, you will be able to 1. Review normal age-related changes to the musculoskeletal system. 2. Identify and apply laboratory and diagnostic data to support the diagnosis of musculoskeletal disorders. 3. Recognize clinical manifestations and provide medical and nursing management for conditions like osteoporosis, osteoarthritis, rheumatoid arthritis, gout, Lyme disease, osteomyelitis, and trauma. 4. Apply the nursing process to patients undergoing orthopedic surgery, including hip or knee arthroplasty. 5. Identify potential complications of musculoskeletal trauma or surgeries. 6. Prioritize nursing care and teaching points for patients with alterations in the musculoskeletal system. 7. Recognize special considerations for patients with musculoskeletal problems and trauma. Age changes, why it matters. Let's start by exploring why age-related changes in the musculoskeletal system matter. As we age, bones become stiffer, weaker, and more brittle. Bone density decreases, leading to a reduction in calcium levels. Posture changes, including the shortening of the vertebral column and thinning of vertebral discs. Height decreases, particularly after age 50, with long bones like arms and legs shrinking. Muscle mass decreases, and muscle fibers deteriorate, resulting in slower movement. Joints, ligaments, and tendons become less elastic, making individuals less flexible. These changes underscore the importance of exercise in maintaining muscle strength and flexibility. Lower back pain. Moving on to a common concern, lower back pain. It's prevalent due to the lumbar region's flexibility, weight-bearing function, and the presence of nerve roots. Factors contributing to lower back pain include lack of muscle tone, excess body weight, stress, poor posture, and various medical conditions. Causes of lower back pain: mechanical strain, instability of the lumbosacral vertebrae, degenerative disc disease, herniation of an intervertebral disc, spondylolysis and spondylolisthesis, spinal stenosis, congenital spine problems. Diagnostic tests for lower back pain. For acute back pain lasting 4 weeks or less, diagnostic tests may include the straight leg raising test. Imaging tests like MRI and CT scans are generally reserved for cases involving trauma, cancer, or suspected systemic diseases. Chronic lower back pain lasting more than 3 months may require additional diagnostic tests such as X-rays, CT scans, MRI, myelogram, discogram, and electromyogram. Common therapeutic modalities: pharmacologic interventions, analgesics, acetaminophen, NSAIDs, muscle relaxants, epidural steroid injections, physical therapy, stretching, strengthening, and flexibility exercises, heat and/or cold therapy, transcutaneous electrical nerve stimulation, TENS, use of corsets and spinal orthoses, alternative therapies, acupuncture, postoperative care for orthopedic surgery. For patients undergoing orthopedic surgery, particularly hip or knee arthroplasty, postoperative care is crucial. This includes use of incentive spirometry, IS, and deep breathing exercises, monitoring intake and output, pain management, potentially utilizing patient-controlled analgesia, PCA, drains to manage postoperative fluids, deep vein thrombosis, DVT, prophylaxis with sequential compression devices, SCD, or foot pumps, and anticoagulants. Postoperative complications: 1. Spinal cord injury. 2. Cauda equina syndrome, compression of lower spinal nerves. 3. Dura tear, requiring patients to remain flat for 24-48 hours. 4. Thromboembolism. 5. Infection. Patient and family education. Patients and their families need guidance postoperatively. This involves 1. Avoiding low, overstuffed chairs. 2. Limiting standing for extended periods. 3. Restricting twisting, bending, and heavy lifting. 4. Using a firm mattress and, if indicated, a brace. 5. Modifying the home environment to meet restrictions. Osteoporosis. Now, let's shift our focus to osteoporosis, the most common metabolic bone disease. It's characterized by gradual demineralization of bone, leading to decreased bone mass and density. Osteoporosis predisposes individuals to fractures, especially in the spine and hips. Demographics. Most common metabolic disease. 10 million in the U.S. with osteoporosis, 44 million with low bone density. National Osteoporosis Foundation, 2017. Characteristics of osteoporosis. Characterized by gradual demineralization of bone. Results in decreased bone mass and density. Predisposes individuals to fractures. Bone density levels. Osteopenic. Bone density lower than normal. Bone density 1 SD below the young adult mean. Osteoporosis. 2.5 SD below the young adult mean. Consequences. Reduction in bone density predicts spinal and hip fractures. Health impact. Devastating health effects. Approximately 20% die within 1 year of a fracture. Osteoporosis pathophysiology. Understanding the pathophysiology of osteoporosis involves distinguishing between primary, idiopathic, postmenopausal, senile, and secondary osteoporosis, resulting from clinical, intestinal, or renal disorders, and glucocorticoid use. Osteoporosis lab and diagnostic tests. Definitive laboratory tests. No definitive laboratory test available for osteoporosis. Potential indicators. Vitamin D levels may be assessed. Calcium level may be considered. Biochemical markers sensitive to bone changes. Bone-specific alkaline phosphatase, BSAP. General indicator of bone formation. Reflects osteoblast activity. Imaging techniques. Dual X-ray absorptiometry, DXA-BMD. Measures bone mineral density. Caution, sometimes used inappropriately for treatment decisions. Some studies suggest it may overrate osteoporosis. Quantitative CT, QCT, for bone density. Noted as a diagnostic option. Osteoporosis management. Pharmacological. Pharmacological interventions for osteoporosis include 1. Calcium supplementation, 1200-1500 mg, D. 2. Vitamin D supplementation, 800-1000 U per day. 3. Calcitonin to inhibit osteoclast activity. 4. Estrogen and hormone therapy. 5. Bisphosphonates to increase bone density. 6. Raloxifene, Avista, as a selective estrogen receptor modulator, SERM. Osteoporosis nursing management. Nursing interventions for osteoporosis include 1. Assessing risk factors and the environment. 2. Emphasizing prevention strategies. 3. Educating patients on medications, safety, and dietary considerations. 4. Encouraging weight-bearing exercises. 5. Monitoring bone density through dual X-ray absorption, BMD, and other appropriate tests. Arthritis and connective tissue diseases. Moving on to arthritis, the inflammation of one or more joints. We'll delve into the various types, encompassing rheumatoid arthritis, osteoarthritis, and gout. Osteoarthritis, OA, pathophysiology. Primary osteoarthritis presents with an unknown cause, while secondary factors may involve trauma, fractures, infection, congenital deformity, and obesity. The risk escalates with age, and it's more prevalent in women. Osteoarthritis clinical manifestations. Clinical manifestations of osteoarthritis encompass 1. Joint pain, stiffness, and swelling. 2. Crepitus, a grating sound during joint movement. 3. Joint enlargement due to bone spurs. Osteoarthritis treatment and nursing management. Addressing osteoarthritis involves 1. Managing pain through medications and non-pharmacological approaches. 2. Promoting joint function through exercise. 3. Assisting with weight management. 4. Educating patients on the importance of rest and joint protection. Surgical interventions for osteoarthritis. In addressing osteoarthritis surgically, various interventions aim to manage pain and improve the overall quality of life for individuals experiencing this condition. Pain management strategies. Initiating with non-surgical approaches. 1. Start low and slow. Employ gradual and conservative pain management strategies. 2. Medications. Tylenol and topical lidocaine for initial relief. NSAIDs, COX-2 inhibitors, and opioids for more severe cases. 3. Joint injections. Utilize hyaluronic acid and cortisone injections for targeted pain relief. 4. Thermal therapy. Apply moist heat for chronic pain management. Use cold therapy to address inflammation. 5. Dietary management. Emphasize weight management as part of pain control. 6. Balance and fall risk. Implement strategies to address balance and reduce the risk of falls. 7. Alternative therapies. Explore OTC topical remedies. Incorporate natural anti-inflammatory compounds such as ginger, holy basil, turmeric, green tea, rosemary, scutellaria, hujang, and omega-3 fatty acids. Non-surgical interventions. Physical therapy and exercise. Engage in physical therapy to enhance joint function. Adopt exercise regimens tailored to individual needs. Long-term planning. Develop comprehensive, long-term plans for sustained management. Surgical options. Joint replacement surgery. Consider joint replacement surgery for severe cases, replacing damaged joints with artificial ones. Arthroscopy. Employ arthroscopy for minimally invasive procedures to assess and address joint issues. Osteotomy. Explore osteotomy, a surgical procedure involving the reshaping of bones to redistribute weight and alleviate stress on the affected joint. Joint fusion. Consider joint fusion for specific cases where the joint is stabilized by fusing bones together. Joint resurfacing. Explore joint resurfacing techniques to preserve joint function. Cartilage repair. Investigate procedures aimed at repairing or regenerating damaged cartilage. Each surgical intervention is carefully chosen based on the individual's condition, and a collaborative approach involving patients, healthcare providers, and specialists is essential in determining the most appropriate course of action. Rheumatoid arthritis, RA, pathophysiology. Rheumatoid arthritis is a systemic, autoimmune inflammatory disease affecting synovial joints, often leading to joint deformities and functional disabilities. Rheumatoid arthritis clinical manifestations. Clinical manifestations of rheumatoid arthritis include 1. Joint pain, stiffness, and swelling, typically affecting smaller joints symmetrically. 2. Fatigue and weakness. 3. Subcutaneous nodules. 4. Anemia, weight loss, and a general feeling of malaise. Rheumatoid arthritis treatment and nursing management. Nursing interventions for rheumatoid arthritis include 1. Managing pain and inflammation. 2. Promoting joint function. 3. Assisting with activities of daily living, ADLs. 4. Supporting emotional well-being. 5. Educating patients on medications and self-care. Gout pathophysiology. Gout is a form of arthritis characterized by the deposition of urate crystals in the joints, leading to inflammation and severe pain. Gout clinical manifestations. Clinical manifestations of gout involve 1. Acute attacks of severe pain, swelling, and redness, often in the big toe. 2. Tophi. Visible accumulations of urate crystals. Gout treatment and nursing management. Nursing interventions for gout include 1. Managing pain and inflammation. 2. Promoting joint function. 3. Educating patients on dietary modifications and medications. 4. Encouraging fluid intake. In conclusion, Nursing care for patients with musculoskeletal problems involves a comprehensive understanding of age-related changes, diagnostic data interpretation, and effective management of various conditions. Whether it's lower back pain, osteoporosis, arthritis, or trauma, nurses play a crucial role in providing holistic care and support to improve patients' musculoskeletal health. As always, stay curious, keep learning, and provide the best care possible. Thank you for joining me in this informative session. If you have any questions, feel free to ask. Until next time, take care and happy nursing.